region. Discussion: the brain damage in tubercular meningitis occurred as a consequence of marked tendency towards regulation, organization and fibrosis of the basal exudate. Again, the site of tumor is more important than its size, nature and rate of growth. So in conclusion, in the present study, most common cause of papilledema in pediatric age group was found to be tuberculosis, either in the form of space-occupying lesion or infection. Again, the incidence of TB is very high in meghalaya, in city area, mostly due to overcrowding and ill ventilation, and in village area due to poverty and malnutrition. Thank you.
Again, did you compare with any other study done in India?
Sir, I searched in May, but there is no such study. But it was the thesis subject of one of my colleagues when we were students. She also got tuberculosis.
How do you expect papilledema in an infant, 1 month child? How often you encounter papilledema?
It is very high.
It's very high.
Very high.
Because the fontanelle is just not.
Yeah, fontanelle is not from.
What precaution you will take during lumbar puncture?
Sir, if it is a mild papilledema, we are doing, but if the papilledema is moderate and severe, before doing lumbar puncture, we give intermittent many drops to decrease the pressure.
Thank you.
Do you have any case of viral meningitis or VDRL positive meningitis? Because this sort of things. Again, in tubercular meningitis, have you got any acid fast bacilli in the CSF or any PCR correlation for those?
Sir, viral meningitis, I got
6 cases here.
6 cases.
What are the viruses?
Sir, that is not done.
Herpes group of viruses, that is.
And the tubercular infection, acid fast bacilli, we didn't get in AFT stain, but ADA value, adenosine diamide, if it is more than 10 in CSF, it is considered to be positive for TB. And predominance of glyphosate, low sugar, high protein, all are suggesting tubercular infection. With clinical symptoms, fever.
Okay. Thank you.
We'll announce the result in 5 minutes.
And we actually presented a paper yesterday where we evaluated the choroidal thickness in the affected as well as the unaffected eyes in acute CSR patients. And what we found that in 11 patients, that the thickness was greater not only in the affected eye but also in the unaffected fellow eye of that patient when it was compared to the age-matched controls. And this is one example. You can see how the choroid is thickened on EPI. This is the fellow eye showing a thickened choroid as compared to the normal eye. So this is a very useful tool, and this could signify that the choroid could be thicker in the unaffected eye, and it requires probably close follow-up of those patients. Coming to another very common use of OCT, that is the diabetic maculopathies, and you can see how you could classify this. It is a maculopathy with diffuse edema or cystoid edema, or a macular serous elevation, or ischemic maculopathy and traction maculopathy. And out of this, the ischemic maculopathy cannot be seen on OCT, so you always need to do an angio to rule out that. And now we always clinically differentiate whether it is a foveal or a central involving edema or a non-central edema, because now the way we treat diabetic macular edema changes according to that. So these are the different changes that you could see on OCT. You can see the retinal profile becoming irregular, the deformation of the foveal depression, spongy edema, presence of ERM or the vitreomacular interface disorder, that is the VMT. You could see small infraretinal cysts, or you could see the serous detachments. You could very nicely see the hard X-rays and the hemorrhages. You could see the ELM being disrupted. And I think again the most important is the ISOS junction, because we are seeing that the final visual potential actually depends on the integrity of the ISOS junction. It is very, very important to study that effect, because you see most of the times, okay, I treated the patient, this is the edema, and the edema is resolved, but there's absolutely no change in the vision of the patient. Now, why is that? So, again, you have to see the details of these layers, and if on starting itself, you have the disruption of the ISOS junction, you have the disruption of the photoreceptor layer, then you can prognosticate to the patient that though anatomically we might be able to resolve the edema, the vision is not going to improve. So this is how typically we see the acute focal edemas, and you can see the intraretinal cyst, you can see the vitreoretinal interface showing an incomplete PVD, and this is how it looks like after resolution, with again a few cysts still remaining. This is just a video of the same thing, again showing the different changes. So again, if you see here, if you take a single scan passing through the fovea, you might miss the edema which is there in the parafoveal region. If you see this, even in the parafoveal region, there was severe edema. And if you go and treat the patient, you might achieve what we call as a normal foveal dip. But there might be some persistent edema in the parafoveal region. If you see the non-foveal dip coming, but if you see here, there is still amount of edema in the peripheral regions. Again, you can see another example. This is a severe intraretinal edema as well as the subneurosensory detachments. And this is how the post-Agaston looks like. And this is very, very important in follow-up cases. And I usually like to do OCTs at every follow-up, just for my understanding of how this patient responds. Because even at each follow-up, depending how the retinal structures come back to the normal, you could have a rough indication of how many injections the patient is going to need in the future. I'll just skip the videos for the lack of time. Again, you can see the severe cystic edemas. So here if you see these structural changes, you can expect that there is a lot of loss of the photoreceptor layers, and you can prognosticate and tell the patient that probably you might need more injections to start with, because this is a severe cystic edema, and this is how it has responded to the first injection, 1 month post-injection. So if you are doing a PRM treatment, then I think an OCT at every visit is an absolute must. In any case, as I told you, I think it is a very good idea to repeat OCT. The use of OCT is, I think, becoming more and more common with cataract surgeons as a pre-cataract prognosis or evaluation, and particularly in diabetics, when you have a certain amount of cataract and you see faint amount of the maculopathy, it's a good thing to do the OCT, because you can get pretty good scans even for a relatively dense cataract. And you can see, and if there is some amount of edema, you can pre-treat the patient, or some surgeons do give intravitreal injections during the cataract surgery or at the end of the cataract surgery to take care of this edema and prevent the rebound edema following cataract surgery. I think another very, very useful example is particularly in patients with proliferative diabetic retinopathy. And, we did have OCT, we did PDR, the proliferative stage resolved, but the vision did not improve or even worsen. And that was because of the PRP-induced macular edema. And to your surprise, if you do OCT in all your patients whom you are doing PRP, you will have a significant number of patients who develop CME 1 or even 2 months post-PRP. So I think this is a very, very good tool. I do it routinely. not only to see the edema, but also to see the vitreoretinal interfaces in a proliferative stage, which I'll show you. Again, this is the CSME. Now, this patient actually has a vitreomacular adhesion. So ultimately, no matter how many injections you give, you're not going to achieve a plaque phobia, because the pathology is not going to get cured by anti-VEGF injections, because it is an anatomical problem causing traction to the fovea, which is causing a pull. So ultimately, these patients might require surgery, or now we have a new injection like a softoplasmin, still not available in India, which would prove to be useful. Again, proliferative diabetic retinopathy, and I think a video here is very, very useful prior to your surgeries, because you can study the adhesions, you can actually plan which way or where to start your dissections and how severe or how thin the retina is. So you could be extremely careful while doing your surgeries. If there is a small, very strong pull, then while doing the last separation of the fovea, you might induce a macular hole. So you can see these scans, these are very, very useful doing surgeries prior to the surgeries. Now if you look at this proliferative diabetic retinopathy and you just do an angiogram, just don't do an OCT, you see the neovascularization, you see the diffuse macular edema, you see the severe non-perfusion, and then you just go ahead and do the PRP. But what this patient actually had was this. So there is no way your PRP is going to be effective in this patient. Ultimately, surgery is required. So this is also very useful in PDR cases. We would switch to another pathology, that is the heredomacular degeneration. Again, I think this is a very useful tool. We do it routinely, particularly in the vitelliform stages, and you all know the different stages. And this is very important to prognosticate again, because you can see the different changes occurring. You can see the areas of the choroidal atrophy, which is seen in the EEI. And you can see the various portions of the retina which becomes extremely thin and atrophied. And this is useful again for prognosis sake. So in all heredomacular degenerations, again, you can combine the OCT with the autofluorescence, which is becoming more and more useful, particularly in the heredomacular degenerations, in geographic AMDs. And you can have both these tools and have a follow-up comparison which would indicate whether the disease is progressing or not. Because both these diseases, in majority, unfortunately, we are not able to do any active intervention except maybe give low visual aids. But it is useful for the patient to know that after 5 years or 10 years down the line, will I become blind? You have young patients, do I need to change my profession? I have a lot of patients who are doctors actually. And they have to be prepared 10 years down the line. And I have a few right orthopedic surgeons who have actually changed into administrative posts because they have these problems. I think
many machines which have the facility for EDI. So 98 machine has a facility for EDI. So most of the machines have the facility for EDI. So when you try to purchase a machine, also ask for the EDI facility should be present. Because we don't know in the future, we are doing retinal OCT today, but tomorrow we also might be doing choroidal OCT, as it's coming in now. So ask for this facility in this course we recommend. And second, the first question is that the presence of CMA only on OCT. It's difficult sometimes to see the OCT. Definitely the subretinal fluid is picked up. So OCT probably not only will become a sponsorship, it may pick up or may not pick up, but I agree with you, the fluorescein would also be a complementary tool. So I would again, as a final message is that the FA OCT go hand in hand. You must do an angiography as a baseline. Even follow up sometimes at 3 months, 6 months, you might like to repeat the angiogram among the OCT. In between, as a injection of proceeding, only the OCT might be now.
Just quickly, because of the lack of time, I will just go through the examples. This is again the vitelliform dystrophy, so you have to make sure you have that scan. You can see the exhibited material through the scan. The foveal thinning and the atrophy provide, which is easily seen. This is again a case of vitelliform dystrophy, which is many a times misdiagnosed as a CNVM. And again, as Kumar said, these cases, I think an angiography is a must to differentiate between the CNVM and the vitelliform dystrophy. I think it's also very useful to do scans in cases of retinitis pigmentosa, because many of these cases have associated CNE, and this is one such case. You can see the intraretinal cyst, and these treatments many times require treatment in the form of oral Diamox or even topical dorzolamide drops, and you can follow up these patients on how they respond to your treatment and do it. I think one of the most common misdiagnosed etiologies of having CNVM are the parafoveal telangiectasia or the MACTEL, and I think OCT studies of these patients in detail is an absolute must. You can see like an inner retinal hole here, almost like a granular hole, but you can see the roof is still intact, and it's very, very common that patients people go on treating these patients with anti-VEGF injections. This will have only a temporary resolution, but again, you will have these cysts which persist throughout their lifetimes. Here's the last few examples. Trauma, again, I think it's good to do the scans of the trauma, not only for the choroidal details, but also for the retinal details. And you can see the choroidal rupture with the presence of the subretinal hemorrhage. And you can very nicely see how the destruction of the individual layers of the retina occur. And this is how it is seen eventually after the conservative treatment. But if you see the choroidal rupture still remains, and you can prognosticate the patient that the rupture actually has healed right through the fovea, and probably you're not going to have that good vision. Again, this is a case of a traumatic macular hole. It's very, very useful to do scans. I think Atul is going to talk about it more. But this is the scans of the traumatic macular hole. This is again a case of Berlin's edema, and acute Berlin edema. You can see the thickened retina, and this is how it responds eventually. This was a traumatic macular hole, and this is post treatment. Actually, it was just treated conservatively, and many a times these macular holes resolve themselves within 1 or 2 months. So it's always a good idea to wait for a few weeks before operating aggressively on traumatic macular holes. Retinal vein occlusion, very fast, very easy, very good tool. Again, you can see the amount of edema, and you can see how they respond to your treatment. Now, it depends on how tolerant you are to the amount of the residual edema. You need the repeated treatments for the ERBO cases. Again, you can see how nicely they resolve. And again, if you follow a PRN, then you can have the OCT every month and prognosticate the patients. And just the last 2 slides. This is again a case of CRBO, severe cystic edema. So I think the rest of the etiologies will be dealt by Atul, and then we will take a few questions.
Thank you, Ale. And so we had introductory 2 lectures and a few specific diseases, and continue on with the diseases to end the lecture by 8:15. So we're covering now ARMD and polypoidal choroidal vascularity, which is called PCV. So what question Kumar was asking, and was that OCT enough to pick up the choroidal vascular membranes? If you pick up the patient early, sometimes you get a picture where there's like a bud growing through, it's disrupting the artery, it's growing from the choroidal side to the subretinal space. It's an early patient who was one-eyed, so he noticed his metamorphopsia and diminution of vision early, and we found that he had developed an early neovascular membrane, his thickness started going up, and as the neovascular membrane, which is ill-defined, although OCT not so well defined, but you can see some fluid starting to appear. You can see the break in the lines, the RP, the AIOC. These lines are very important. You should see for these lines, as I said, ask those 4 questions. Vitreoretinal interface, the foveal contour, the retinal architecture, and the lines. 4 things you ask yourself and interpret OCT, you should not be making any errors. And as you see, after the injection of anti-VEGF, the patient's foveal tip is now nearly normal. And then we go on to a variant called polypoidal choroidal vascularity, which was described by Yarmuzi. Many of us have
heard about it, but this is what it looks like. It's polyps at the end of the choroidal vessels, the small choroidal vessels. There's some kind of abnormal polyps start developing with age. It's a variant of AMD, wet AMD. So what they say, these polyps can be seen only by ICT angiography. This is ICT angiography done on a confocal SLO system. And you can see the multiple PDs, serosandwich PDs, which have optical echoes within the PD. This is thought to be hemorrhage or heat within it. And they say that under the PD, what you can see, these irregularities are actually the polyps. This is a case where there is a occult choroidal neovascular membrane, late fibrovascular PD, which is leaking, not very intense. This late leakage in a fibrovascular PD or late leakage of another region is an occult CMEM. You can see a notch over here, which is usually signifies the presence of a choroidal neovascular membrane. And during the OCT, you can see the PD, which is hyper-reflective. As I said, reflectivity is the most important thing to look for, the sound reflectivity. And that what gives us a false pseudo-color image, or you can have a grayscale image also. And the optical EFT is a serious fluid. And sometimes the PDs get ripped. They can undergo spontaneous ripping or because of anti-VEGF injection or photodynamic therapy, so it's immaterial. It's not that only anti-VEGF injections cause a rip. And the scan, the raster 5-line scan shows you the rip which is present. And if there is a serious PD, you see the choroidal reflectance is quite moderate. While if there is blood beneath the RP, like a hemorrhagic PD, the thing is what you get the penetration to the blood is hardly much because the sound gets reflected back. The sound does not, the light does not pass through, and the light gets reflected back from the blood. And so what you get is the reflection of the choroid are severely attenuated. The light reflection of the choroid. So you get some kind of a gap in the choroid, which is actually a pseudo gap because of the hemorrhage. So macular holes cause a disruption of the retina, and you can have cystic fluid. And this disruption tells you that the biggest advantage of OCT is you can do quantitative imaging, quantitative scanning, and you can measure the base as well as the height of the hole. And after the treatment, you can see after the macular hole surgery, there's a small subsensory, clear, eco-free zone, which is actually a small subsensory fluid still accumulated there. And then we go on to just to tell you that these lines, the height and the width is very important for base diameter, because if the value of height upon the base diameter is more than 0.5, the chances of hole closure are very high. So you can actually predict the hole closure based on the preoperative macular hole index. And again, I said the line is extremely important from the point of visual acuity return. When the patient says I've undergone some macular surgery, or is an ARMD patient or a CSR patient, or for that matter any of these ERM, VMT patients, all of these lines get affected. So look for the RP, you can see above that the ISOS line is very irregular. It's hardly present. So the ISOS line being absent, this patient's visual acuity would be disturbed, though his hole is closed. And that's the cause for his disturbed visual acuity. But not to fear, but in time sometimes these lines do start appearing. And epiretinal membranes can be of various types, of very gross, thick epiretinal membrane can distort the retinal architecture to a very big extent, which can't be imagined on a clinical examination with a 90 diopter lens or a contact lens. You can see the macular drag which is there because the epiretinal membrane is pulling it superiorly. This whole macula gets pulled with the distortion of the dip as well as the foveal interface. You can see the ear which is present, and you can see all the lines, of course, the architecture, the lines are all, except for the RP is absent. And you can see there's a membrane here which is causing a cystic edema but not causing much of a distortion of the retina. The region of the macula. You can have a pseudo hole. You can differentiate a true hole from a pseudo hole based on OCT. Pseudo hole has steep lines, steep walls. The walls are very steep. Unlike a lamellar hole which has clefts on each side, and the thickness is normal. So the pseudo hole is actually not a true hole. It's usually associated with the epiretinal membrane. The epiretinal membrane pulls the retina apart in the region of the fovea and causes a pseudo hole. The treatment of choice is macular ERM surgery. The pseudo hole should close. Vitreomacular adhesion, vitreomacular traction, I quickly go through. We are coming towards the end of our time. So it's vitreomacular adhesion, which is the predisposition or which is in the evolution of a macular hole. The first thing which usually occurs is the vitreomacular adhesion. There is an abnormal adhesion of the vitreous to the macula. When the vitreous fails to separate from the macula during normal liquefaction and weakening, of normal adhesion between the posterior vitreous cortex and the eye line. This is an unfortunate thing, we can't predict it, but if There, the OCT is a investigation of choice to pick it up. If you have it, you can do either when there's initial no symptoms, you may do nothing. Even if it's symptomatic with a VMA, you may do watchful waiting till such time that his deterioration of vision occurs and he starts showing deterioration of vision as metamorphopsia. So this VMA then proceeds to something like retromacular traction, where the perifoveal detachment occurs, but the fovea is attached to the jelly, which is cortex, and it pulls. And this pull further causes a mechanical tear over the retina, and one of the flaps are seen pulled up. So this is the usual sequence of events. You can see clinically a patient showing who comes to you in the outpatient or the clinics with a distortion of vision, with a disturbance of vision, might show up a picture like retromacular traction, which further leads to a hole formation. So there is a perifoveal, perihaloid detachment of the cortex, but not in the fovea. The cortex stays attached. So you can have optic nerve pits. Again, a diagnosis totally done by OCT. It's not a fluorescein diagnosis. You can probably just make out some idea of a macular fluid over there, but you don't know whether it's macular fluid is a CSR, whether it's a CME, or whether it's because of something else. Though it can be clinically seen, but the exact structural changes will be picked up. Here's a multi-layered species over here. And the multi-layered species is a sine qua non or hallmark of optic nerve pit with macular maculopathy. You have multi-layered species. You have multi-layers in which the species occurs when there is an outer lamellar hole. You can have an outer lamellar hole or a serious detachment. So we've been doing a lot of these surgeries now whenever we get such cases where they say that vitreopapillary traction is the cause. And subsequent to surgery over a period of 6 months to 1 year, it usually takes a long time. And we don't put gas or oil because it may go in subretinally and then submacular, or the oil may even transmigrate to the subarachnoid space of the brain. So there are clinical reports to that effect. So one should not ever put oil or gas, maybe put, but oil never. And so we leave it under fluid-filled cavities. And coming to the end, the last is a case which we are again doing recently. We switched to a triple procedure which we put the tissue recombinant TPA, and we add Avastin along with the air bubble in the submacular space using a 41 gauge transformation needle. In the supranasal aspect, the 41 gauge transformation needle creates a sense retinopathy. If you have blood like this, when you do the OCT, the blood layer will cause hyper-reflected echoes from here. The reflections are hyper-reflected, and below there is a shadowing because the light is not passing through. And when you do the surgery is over, you can in fact see the patient's bubble is still there. It's done for 1 month post-op CTFA bubble. After the retinopathy has been done and the 3 injections have been put in, the 3rd injection is actually not an injection, the air bubble. And then you can see the foveal dip is there, the architecture is maintained, the interface is all normal, and you can see some degree of the artery is there. But the patient did recover a very useful vision. There is a small, probably a hemorrhagic PD, I think, which is still present, but you have to follow up such patients for 8 weeks. So in the end, before concluding, I just want to say the non-invasive characteristics of the OCT have created a trend towards less frequent use of fluorescein, but that does not mean fluorescein is out of vogue. It is still part and parcel of a gold standard for retina. People who practice medical or surgical retina, it is still there and it's very much going to be there as the way I see it, the first time is there. But there's less frequent use in the serial follow-up, especially in AMD patients where you want to re-inject. Nowadays, anti-VEGF injections are very important for all kinds of diabetic macular edemas, or for AMD, wet AMD, or for even vein occlusions. You have to give repeated serial injections. So each time the patient does not need to be subjected to an invasive FFA, but rather non-invasive OCT. But at intervals, when you feel the necessity, if you may actually add on the fluorescein to such patients. The only thing about OCT is just screens the macula. It does not tell you the region of the equator or anterior to the equator, and that does not provide you provision state. If there is ischemia of the macula, it's not picked up. If there is ischemia anterior to the equator or even in the region of the equator, it may not be picked up. So fluorescein is where scores over the OCT in such areas. So they've got their own advantages, and you can say disadvantages, some of them. So you just complement each other with those two tests. Thank you so much for patient hearing early morning. It's the height above the base diameter should be more than 0.5. And if it's more than 0.5, you can be rest assured there is a high chance of the hole closing. If the flat load holds the MHI, the macro load index keeps going down. There's a American Journal of Ophthalmology article, I think, in 2003 or 2004. Just Google it, search it, you'll find the article. But this MHI is a great value. There are other indexes also, fold form factor and all that. But macro load indexes, I found personally, we published this article also, and it's useful. You just have to measure the height. There is a facility for the cursor on every OCT machine, and you measure the base diameter, and then divide the two and see the values.
Yes. Yeah, I think even in hazy areas, if we do it, I mean, not in an extremely dense cataract, but let's say grade 3 cataract also, if you do it carefully, you are able to get a full scan. And actually, we use this even in uveitis patients now. We use uveitis guided treatments because even in the presence of severe vitritis, we are able to get a pretty good view of what's going behind the hazy vitreous in the underlying retina. And we actually use the OCT to follow up these patients and base our treatments just based on the OCT.
Do you use any eccentric viewing of the patients by taking this scan?
Not actually. Because we're interested, I mean, for prognosis sake, macula is most important. But there is a lot of interest in doing peripheral OCT now, which is again a very different specialty, but not very easy. Rima?
Yeah.
Rima is one of the experts of OCT in this country.
I wanted your comments on what is your comment on the newer concept of the IS-OS junction not being the IS-OS junction now, and it's more of an inner segment ellipsoid, the eye cell concept. So I wanted to know what are your comments on that?
Can you just say again, it's not called IS-OS junction, it's called what now?
Eye cell, capital I, capital S, and then small e-l.
Yeah.
The inner segment ellipsoid.
I'm not aware of that.
I think, there is thought to be a change in the concept of the IS-OS junction. I think it is still evolving. I mean, we'll have to study, we'll have to go back and see our patients again. And I think this is a newer concept.
Yes.
So, we didn't bring this deliberately because this was a very new thing.
It's still evolving.
It's an evolving thing. And again, the OCT technology itself is evolving.
So, one thing is the cone outer segment tip is
That's right. Yeah.
Cone outer segment tip is
Yeah, first I think we used to talk about the cost.
That is the
Total
outer
sector,
segment.
outer segment tip. So now I think the cost is being overtaken by
It's ellipsoid.
like
ellipsoids.
the ISO has been overtaken by the ELM. You say ELM is more important for cost came.
Yeah, that's fine. ELM is definitely.
Cost came recently about a couple of years back.
But I think now we're talking more of the ISL rather than the ELM. So I don't know.
We also have a new sweat source OCT technology which is coming. And that will again change our concepts of how we deal with it.
So volume testing is good for the ophthalmologist as more and more comes in. They use OCT for various pathological conditions of the macula.
Thank you all and thank you Dr. Atul for...
Is when the object is seen at the fovea of the eye, and if the motion is more than 5 degrees per second, then it leads to orthodopsia. And we all know that the peripheral retinal image is always unclear. So there are 3 mechanisms which help in getting a clear image on the retina. First is the fixation. So the visual system always tries to detect a drift of the retinal image, and it programs corrective eye movements and suppresses the unwanted cycles. In addition, on head tilt and other such movements, we have got the vestibular ocular reflex which compensates for the eye movements. And the third thing is the nuclear integrator, that is the brain, which sustains an eccentric eye position against the elastic forces of the muscles and the ligaments. So the smooth visual fixation mechanism prevents the eye drifting away from a stationary object and relies on the microcellular portion of the visual system, and it's got a very fast response time. And so if there's a delay in the response time from this microcellular portion, then we might end up in having nystagmus. The visual cortex, the cerebellum and the pontine nuclei play a very important role in the maintenance or prevention of nystagmus. So signals from the visual cortex will be sent to the cerebellum via the pontine nuclei and the middle cerebellum peduncle. And the output cells of the cerebellum are the Purkinje cells, and any disintegration of this Purkinje cells will give rise to pendulum nystagmus. So because of these pontine nuclei and the cerebral nuclei, the convergence position of the eye is maintained as the eye moves together in different directions. The classification of eye movements is based on this particular classification, that is the CMAS classification, which was coined in the time 2001. That is the classification of eye movement abnormalities and strabismus. Broadly, if you look at this, it includes nystagmus and other oculomotor oscillations. It is not the physiological group, the pathological group, and it is also not other conditions like saccadic inclusions and oscillations and generalized problems. So the physiological fixation movements include the microtremors, the slow drips, and the microsaccades, which assist the retinal and the visual function. The physiological nystagmus includes the vestibular nystagmus, in which the eyes will move away from the cold or the warm target. The optokinetic nystagmus, which can be illustrated by rotating a drum, and there is the rectilineation movement of the eyes and the eccentric gaze nystagmus. And all these are believed to assist retinal or visual function. In the pathological nystagmus, we have got different types like the infantile nystagmus syndrome, the FMNS, and the SNS. So these are different kinds of nystagmus, and what we usually go individually into each type of nystagmus, and we just highlight the key points so that we have better understanding and easier recognition of these cases. So let's first look at the infantile nystagmus syndrome. Previously, this was called as the old congenital and the motor and the sensory nystagmus. Now, this happens in infants. It has got an accelerating slow pace. It is conjugate. It could be horizontal or torsional. It can be associated with albinism or achromatopsia. The important things are the ones which are underlined here. It dampens on convergence. It increases with fixation. There is a null zone. So let's look at this particular child. So this child has got a head posture. So when the child is turning the face to the right, you can see there is a lot of nystagmus. In straight gaze again there is nystagmus. But when the child turns the face towards the left, or there is a head turn to the left, the nystagmus reduces. So there is a null zone which is present, and this child is having associated head posture. And it has also got a latent component. The fusion maldevelopment nystagmus syndrome, the FMNS, was the old latent or the manifest latent nystagmus. Again, an infantile onset nystagmus, usually conjugate, horizontal, and uniplanar. And if there is convergence, it can get blocked. The head posture is associated with the fixing eye in adduction. It decreases with increased fusion and decreases with age. So when we cover one eye, the nystagmus is more prominent in these cases. So this is a fusion maldevelopment nystagmus syndrome, and the key point here is that it is a latent kind of nystagmus which can be blocked on excited convergence. It will decrease when there is increased fusion, and it also decreases with age. This Marcus Nucleus syndrome is very classic and typical because it happens in infants. It is associated with abnormal head posture and head oscillations. It is a high frequency nystagmus and usually disappears by childhood. It can be disconjugate and be asymmetric, and usually it disappears by 2 to 8 years of age. So here you can see in this particular child that child has a high frequency nystagmus and also got these head oscillations. The vestibular nystagmus would include peripheral vestibular imbalance, central vestibular imbalance, and central vestibular instability, or the periodic alternating nystagmus. Let's come to the first one, the peripheral vestibular imbalance. Now, all these vestibular nystagmus will have vertigo, nausea, dizziness, oscillopsia, and all these problems. Usually they are of acute onset. The important thing about the peripheral vestibular imbalance is that it is suppressed by visual fixation. The central vestibular imbalance kind of the vestibular nystagmus is poorly suppressed by fixation of a visual target. And again, this is for the same kind of symptoms: vertigo, nausea, dizziness, oscillopsia, usually of acute onset, and the patient has an unsteady gait. The central vestibular instability, also previously known as a periodic alternating nystagmus, is again extremely typical. It is associated with periodic alternating head turns. This nystagmus is little affected by visual fixation. the head usually turns in the direction of the quick phase and the eyes just move in the direction of the slow phase and thus minimizing the nystagmus. And because of these head rotations, the nystagmus can sometimes get dampened. So this is a periodic alternating nystagmus where there is periodic alternating head turns. The gaze holding deficiency nystagmus would include the eccentric gaze nystagmus, in which when the patient attempts to look eccentrically, the direction of the nystagmus will reverse, which is called the centripetal nystagmus, and after the eyes come to the center, the quick phase will come to the opposite direction or a rebound nystagmus. So here the quick phase is always away from the center. But in the gaze instability nystagmus or the runaway nystagmus, the slow phase is away from the center. Now because of vision loss, again, there could be different kinds of nystagmus. It could be pre-chiasmal, chiasmal or post-chiasmal. The pre-chiasmal, especially with bilateral vision loss, will end up in a jerk nystagmus. With monocular vision loss, it will end up in a pendular nystagmus in the blind eye. The chiasmal nystagmus is very typical. It is a seesaw nystagmus, usually bitemporal field loss. And the post-chiasmal nystagmus is a low amplitude horizontal nystagmus beating to the side of the lesion. There could be other kinds of pendular nystagmus again, or nystagmus associated with diseases of central myelin. So we could have a demyelinating disease, or we could also have problems like internuclear ophthalmoplegia, like in this particular patient. There's absence of abduction in the left eye. Now, in other cases, the nystagmus could be associated with tremors of the palate, which is called as oculopalatal myoclonus. So this is associated with palatal tremors and it would be associated with brainstem disease. In addition, we have other kinds which will be associated with Whipple's disease, in which there is GI events, oculomasticatory oscillations and vertical gaze palsy. Ocular bobbing refers to rapid downward eye movements. It's usually because of one-time damage. Lid nystagmus can also be associated with vertical nystagmus. Upon the secondary inclusions or oscillations, we have got the square wave jerks, which are bilateral involuntary, small faster movements which return very fast within 200 milliseconds, square wave jerks. If they return within 70 to 150 milliseconds, it is square wave pulses. We have also got the static pulses in which there is a drift away from the fixation point followed by a rapid drift back. We could have induced convergence interaction nystagmus as seen with various dorsal membrane lesions where there is light-gain dissociation also. We could have the dissociated ocular associations, usually like the unilateral kind of movement which is seen in the abducting eye and internuclear ophthalmoplegia. And then hypermetric saccades are the ones which are the overshooting saccades. So we overshoot the target and they then make corrective movement. We've got the macrosaccadic oscillations, in which there are back-to-back saccades which are happening all the time, which are trying to interrupt the fixation. We've got ocular flutter, which can again interrupt the fixation. But the only thing is that there is not a big intersaccadic interval. Superior oblique myoclonus is a very typical condition in which there is monocular blurring and it is brought about by looking downward or by tilting the head towards the side of the affected eye, usually following propter palsy. So in summary, there are many types of nystagmus. The old motor and sensory classification is possibly obsolete now. There are very classic key differentiating features which we can use to classify the kinds of nystagmus. Thank you.
The pathophysiological mechanisms of nystagmus and really not very well understood, but in last few years since we have the eye movement recording systems, we have been able to differentiate the different types of nystagmus that we would see, and we used to divide them into say sensory nystagmus or primary infantile nystagmus versus a neurological nystagmus and physiological nystagmus into various subcategories as we had shown to you. In brief, Ramesh, if you can just give them two take-home points on the chemical pathophysiology that they need to know about the causation of nystagmus and what they should know about the classification of nystagmus, which can very, in a very practical manner, can differentiate patient of nystagmus and which category of management they would put in. If you can convey in a very short take-home message.
Yes, in very short, I think usually the vertical nystagmus are the ones which are usually the pathological ones, and usually the congenital ones are the ones which are the safe ones. And these ones which will usually have head posture and such kind of problems. So the most common type of nystagmus will definitely be the infantile nystagmus syndrome, possibly followed by the fusion maldevelopment nystagmus syndrome or the latent nystagmus. I think the key things which we need to do is look at the fixation and look at any kind of refixation movements, associations like head posture, close the eye and see if there is any latent nystagmus. All these will help us in differentiating the key types of nystagmus.
Sure, Ramesh. I want to add a few points in his presentation. One is there are so many phenomena that happen in nystagmus. In fact, some amount of small eye movements are necessary to have good vision. If it goes beyond certain amount, as he presented in his first slide, it produces oscillopsia or significant deterioration in the vision because there is no formation that is taking place, no meaningful formation that is taking place. So all that we are looking at in patients with nystagmus, wherein we are looking at the vision, is the amount of oscillation that is taking place, which allows good amount of fovation. This is one thing that I understand. Second thing that I understand from this presentation is this nystagmus is not to be divided into a sensory defect kind of a nystagmus or a neurological causation as a cause of nystagmus. Rather, this is an abnormality of a pursuit system, especially in the infantile nystagmus syndrome. If you have other kinds of associated diseases which are neurologically localizing, you may still get the same kind of a nystagmus as you would get in infantile or primary without association of sensory defect. I would also like to add one more point over here is, though there are 9 different types of nystagmus that is mentioned, 6 plus 3 prechiasmal chiasmal type, you can broadly divide them into an infantile nystagmus syndrome and the syndromes where there are associations. I think as we proceed to the next few presentations, it will be more clear for you. Ramesh is not yet ready with his presentation, so I will take over the next presentation on the video nystagmography and few other investigation modalities which will help you understand nystagmus better. Thanks a lot, Ramesh.
I'll be basically showing how do you basically in the clinic do an evaluation for a nystagmus. This is not including of any kind of video histography or something. What information you can get with the basic clinical examination in the clinic for these patients, and how do you, because your classification into congenital, physiological or acquired depends upon your clinical evaluation. At the same time, you will know which direction to go next, whether it's simply physiological or acquired. So I will give a broad idea about this, and this is very important because for a heart problem we need to do an echocardiography, right? So for clinical evaluation, all the waves are seen, but we cannot still perceive everything. That's why the video nystagmography is still required. I just want to begin with this case. This is diagnosed as a case of nystagmus. What you can see here is child is putting this thirsting movement to the right as well as to the left. So what exactly is happening? This is not a case of nystagmus. This is a typical case of saccadic initiation failure, otherwise called as congenital oculomotor epilepsy. So this is not typical nystagmus. You can see that he puts his head thrust movement to see this because he cannot initiate this saccadic movements. And the second thing I want to show here is sometimes in the clinic you may not be able to see this thing, and this is given by the parents because at the home what they examine, they can give you some video clips. I will play it again for you. You can see this a small downbeat nystagmus. You can see this is developed at 1.5 months of age. With the clinical examination you may not be able to get, but sometimes it's worthwhile looking at the videos. And this is courtesy the Beamer. You can see the head nodding typically, which is seen in this patient with lot of head nodding with nystagmus. And this is typical nystagmus, which is not a physiological one. You can see that left gaze is more than the right gaze, and up gaze and down gaze, the direction is not changing. So I just want you to see this video. So basically 3 things you need to answer, whether the nystagmus is physiological. If it is not, you need to realize whether it's congenital or acquired. These 3 things have to be made sure before you diagnose the patient. And with the infantile, there are different causes for this thing, which I will not go into the details. And with the clinical classification, you need to also know the manifestation and pattern of manifestation, whether it's manifest, whether it's latent, whether it's manifest latent. Sometimes you might have to do even slit-line evaluation to get this latent nystagmus or a manifest latent. Without that, you may not see these micro movements and the direction, whether it's horizontal, vertical, or rotatory, and the pattern of movement, whether it's jerky or pendular. With the clinical evaluation, I would start with age of onset, complaints, oscillopsia, vertigo, and blurred vision. These are important things. Mostly takes you towards the acquired etiology, history of swing or strabismus, any systemic illness, and also occupational history as well as family history that you take in many patients. Head posture. As soon as the patient comes to you, I think this is one of the most important things you need to look at. And swing and strabismus evaluation, extraocular motility. Sometimes strabismus as well as nystagmus evaluation can go hand in hand, and a thorough ocular examination and a comprehensive evaluation is definitely required. What answers you need when you begin? I am specifically talking about nystagmus here. I am keeping aside the strabismus part. Is it seen in primary gaze or is it gaze evoked? Second thing is whether it's jerky or pendular. What is the amplitude? How much it moves, whether it's fine or coarse? What is the speed, whether it's slow or fast? What is the direction of fast component? And the other question is whether it's conjugate or disconjugate. And where do you see the null zone? It can be in right, it can be in the left face-down, or it can be in the primary position. Effect of occlusion or examination of the slit lamp. This is again important to pick up the latent nystagmus. And this is the simplistic way of drawing this. If you want to draw, and if your colleague wants to see what's happening over a period of time, what is the follow-up, you can see that this is the low frequency. The length of this line tells you. You need to have your own nomogram to document this. It's not that this much is this much amplitude. You need to have. And this is the frequency. If you put more lines, it's high frequency. If you put less lines, it's less frequency. You can see the direction of the arrow. This is where the fast component is there. And upbeat and downbeat. And if you have circumrotatory, you can put this rotation marks there. I want you to see this video here. Can I have the mic, please? So it's just showing that whether you need to make sure whether it's a jerk nystagmus or rotatory. This is the typical jerk nystagmus. You can see the small amplitude which is seen with the higher frequency. The frequency is a little bit larger. And there is a slow movement to the right and fast movement to the left here. And you can also classify based on the etiology, whether it's physiological, pathological. This is typical end-gaze nystagmus. This is an optokinetic nystagmus with the drum, you can see that. And the pathological nystagmus, you have congenital as well as acquired. There are some differences of opinions with this. I'm talking about the basic thing. Can we have a mic, please? Probably I have to run this without the mic. Okay, I would just end with another video here. This is opsoclonos, again, courtesy Dr. Eamer. You can see the irregular, erratic movement of this eyeball, which is very fast. And also, you can see a typical update. Okay, I think I'm done. So, I will just end with this two videos, if I can. This is a typical periodic alternating nystagmus. Suddenly the patient changes his head position. He was fixating with the right, and what you can see is a seesaw nystagmus. He has a midline defect there. It's a typical seesaw nystagmus, what you are seeing there. And this is one thing I want everybody to have an attention here. You can see the nystagmus on the right case and left case. Compare between the right and the left. It's fast moving on the right case. This is on the right case, and compare with the left case. So this is difference in the frequency and amplitude. I can show it once again. See the amplitude and frequency on left case now, and see the amplitude and frequency on the, this is again on the left case. This is on the right case. There is a significant difference. So she did not have any nystagmus in primary position, and these are subtle signs. This is called Brunn's nystagmus. Typically in Integration, they will have a typical tumor in the cerebral quadrangle. CP angle tumors are correlated with Brunn's nystagmus. And this is superior oblique myoclonia. I will end my talk here. Thanks so much.
I would take two questions if you have in the audience. Do you have any questions? Can I invite Dr. Sharma if you have any additional comments for this or even the previous presentation?
I think as time is short, we can go through. If there are anything, we'll talk about later.
You mentioned occupational history. Is it just part of the examination or is it something significant?
Yeah,
Family history I can understand.
Yeah, it's just a part of examination as well as treatment strategy and whatever. I think it's not related to anything.
Thanks a lot.
Video microscopy or other measurement recording systems and other investigation modalities and patients to this nystagmus. This is going to complement the presentation of Dr. Ramesh. It starts with the kind of setup that you require for performing the video microscopy. You don't really need a big laboratory kind of a thing. You just need to have an instrument, either a remote recording system or an iOC which has an infrared camera like this with a customized notebook right in front of it and an interface controller which converts the signals into the digital signals, the analog signals are converted into digital signals, and then you can begin the recording with various protocols, usually around 9 to 12 different protocols which are available to record nystagmus. These goggles are also available with the abnormal head rotation detection device, and simultaneously with the nystagmus you can also record the head movements. The video microscopy would begin with the good centration of the goggle right in front of the moving eye. Either it can be done on both eyes simultaneously or you can do one eye at a time. And then you can select the protocols like a tracking protocol, saccades, spontaneous nystagmus, orthopaedic nystagmus, the right, up, left, down, and so forth and so on. The machine itself will tell you the presence or absence of abnormality in terms of the velocities, and it will tell you about the intensity as well as frequency. But there are few things which you will have to read it yourself, like this one. You need to have the differentiation of the quality of nystagmus. That means in the first panel you are seeing pendular nystagmus, which can be seen in an infantile nystagmus syndrome or more frequently in pathological nystagmus, especially when associated with certain additional features like asymmetric nystagmus or distributed nystagmus. You have the second panel which is showing a slow phase in a jerk nystagmus which is of accelerating type, which is quite typical of infantile nystagmus syndrome. slow phase, or as decelerating slow phase, as you see over here. And last but not least, the linear slow phase with jerk nystagmus is more typical of vestibular nystagmus or neurological nystagmus. The video nystagmography would, in this patient, show up a slow decelerating phase as you see over here. And when you see this patient in the clinic, it is very difficult to differentiate this patient having a jerk nystagmus but no related component because there is already a meninges latent nystagmus. So for this particular type of patients, when there is strabismus along with nystagmus, it becomes very important to do video nystagmography for any other eye movement recording because correction of the strabismus can convert this kind of meninges latent nystagmus into a latent nystagmus. As you see in this particular printout of this past patient which is also. And post-operatively there is significant reduction in the nystagmus or near evolution of nystagmus. Another important evaluation that you would do in a patient with video nystagmography done is look at the fovation in these patients. Fovation is within 5 degrees when the eye is in the slow phase, is the time when a meaningful vision is acquired, and this fovation time is related to the potential vision of this patient. And potential vision of this patient can also be calculated using NAFX or ANF. These are basically the qualities which can be either manually calculated or automatically acquired to find out what will be the effect on vision once you perform any intervention for this patient. Also, when a nystagmus matures, for example, a congenital nystagmus or an infantile nystagmus child comes at 3 or 6 months of age, you might see a peculiar kind of a nystagmus, and as it matures, you will find it getting converted into a jerk nystagmus, and there is an increasing amount of foliation, either with an intervention or with the maturity of the child. Video nystagmography will also help you to find out the kind of improvement that takes place in the patient in terms of the motor outcomes. As you see over here, this particular patient, before giving an AIOC eye drops, the brinzolamide twice a day, after 1 week you find a significant reduction in the frequency and due to an improvement in the foliation, which correlates with the vision improvement that takes place in these patients. As Ramesh had mentioned, periodic alternating nystagmus you need to look at in every patient with nystagmus, more so if there is any albinism, because around 35 to 40% patients with albinism will have a true periodic alternating nystagmus. And the way to differentiate it from a pseudo-periodic alternating nystagmus, as you see in this particular slide, is changing fixation. This can be very easily picked up with a video nystagmography. When there is a change in the fixation, the eye switches from one eye to the other, fixation switches, and there is a change in the nystagmus. It is a pseudo-PA, and it won't respond to the conventional treatment for periodic alternating nystagmus, while a true periodic alternating nystagmus would respond to baclofen or even to muscle TNR. Another important area where the electronic movement eye movement recordings would help is patients who are young and have head oscillation. You want to find out whether this is spasmus mutants or this is other neurological abnormality and avoid any radiological investigation. In spasmus mutants, when you record the head movement along with the eye movement, you will find it to be 180 degrees out of phase. That is, total out of phase movement recording will take place. So when the eye moves to the right side, the head will move to the opposite side to neutralize, and it is in the best interest of the vision. This is quite pathognomonic and happens only in patients with spasmus mutants and not in other head oscillations associated with this nystagmus. The presence of this kind of nystagmus on the eye tracking, as you see in the 5 months or 10 months eye tracking in a patient who is keeping the head turned to one side, you can very easily figure out if the abnormality that patient has in the tracking behavior, which post-operatively after doing a Castellmo-Anderson procedure or an augmented Anderson procedure would decentralize, and over 3 months time you find the eye tracking to be significantly improved, vision is significantly improved, frequency and amplitude significantly reduced, which correlates with the child's overall visual function. May not be just the visual acuity. The video recording of nystagmus is helpful to differentiate the kind of dampening in nystagmus that is taking place. Whether it is pure convergence damping that is taking place in the upper panel, as you see on the right side, you have the patient without looking at a near target, while following look at a near target, the patient is having a significant gaze damping. So you can utilize two strategies to improve vision in this to situations where you would like to perform a neuroimaging or an ARG study in patients with nystagmus. In fact, the data shows that in around 90% patients who have nystagmus, whatever may be the frequency and different types of nystagmus, you have a chance that you will pick up a pathology in the sensory system or a neurological system in the anterior visual pathway. The most important features which should suggest you to perform an MRI or any other neurological investigation is presence of a schizoid nystagmus or a significant vertical component in a nystagmus or a pure vertical nystagmus. A patient who has got pendular nystagmus which is of asymmetric variety or is unilateral or is associated with any signs of optic atrophy or optic hypoplasia, or in patient who have abnormal vertical cocaine, abnormal gases, either up gaze is absent or is absent in down gaze, I think you are definitely justified in doing a neuroimaging in such patients. This is the patient who has got small vertical pure pendular nystagmus. As you see, in doing an MRI reveals arterial malformation with hydrocenicomania. This is the kind of EMR recording this patient has. In the lower part you see the nystagmus waveform, while in the upper part horizontally you don't have anything. And when you treat this patient, you can see very significant improvement that takes place from your EMR. However, the patient may or may not be able to appreciate the difference that is or improvement that is taking place unless you really increase the dose of memantine and give a high dose memantine for these patients. This is another video histography of the patient who has got a significant vertical component which cannot be detected in a routine clinical examination. In clinical examination, it appears only a pure small frequency, low amplitude horizontal nystagmus. But when you perform an EMR, you realize there is a significant vertical component, and presence of vertical component in patients with nystagmus suggests that you should look at anterior visual pathway in more details. Patients having relative after-pupillary defect also should go for the evaluation either in ERG or more detailed evaluation of the fundus. ERG is a must in patients who have paradoxical pupillary sign. It has around 95% specificity and around 70% sensitivity. And how you evaluate this is you keep the lights on, look at the pupil, keep the slide light on the pupil and switch off the room light, and instead of pupil becoming larger, you will find it constricting. This is a definite sign of paradoxical pupillary sign, and this patient suffers from retinal dystrophy. We have picked up a significant number of patients purely based on paradoxical pupillary sign having retinal dystrophy. Some patients would also have photophobia in patients who have dystrophy. It can be associated with other abnormalities, but which can be detected even without an ERG. Patients who have night blindness with nystagmus are likely to have congenital stationary night blindness or retinitis pigmentosa, all of them need to get an ERG done. Patients having a history of breathing problems are quite specific for Joubert syndrome and should, so having nystagmus and a breathing problem should also go for an ERG. And a patient having nystagmus with sensory level hearing loss, or of course as we discussed, with night blindness should also go for an ERG test and rule out pediatric evaluation of paroxysmal disorders. And I'm sure you are all aware of different types of patterns of ERGs that you would see with these different types of retinal dystrophies. As we just discussed, presence of a large